Hi, everyone. Welcome back. I know people are just joining us back to our second session of the afternoon of our program. Again, my name is Rachel Lieberman. I am a director here at the Celiac Disease Center on behalf of my colleagues, Dr. Ritu Verma, Dr. Valerie Abadi, who is our Associate Director of Research here at the Celiac Disease Center, as well as Dr. Carol Semrad, who is with us as a senior leader here at the Celiac Disease Center. We are thrilled to open up our next part of our program. We have a fabulous afternoon program scheduled, although it's still morning here in Chicago. We want to thank everyone. Few housekeeping, please utilize the Q&A function for questions. We will be hosting, again, a Q&A panel at the end of our presentations of this session. And for CME accreditation, again, if you refer back to the emails that I've sent, there is an attachment of how to claim your CME credit, as well as on the website for the program. So we are so thrilled to have everyone. I am so happy to welcome Dr. Valerie Abadi and Dr. Carol Semrad, who will be moderating this afternoon session with us. And I'm going to turn it over to the two of you. Thank you so very much.
Thank you, Rachel. It is my pleasure now to introduce Dr. Christophe Cellier. He's a gastroenterologist at the Georges Pompidou European Hospital in Paris, a professor at René Descartes University, and a member of INSERM, which is a prominent research unit dedicated to intestinal immunology in France. And he really did much of the work to define both the immunology and clinical presentation of refractory celiac disease. And I might add, in the United States, we would call him a triple threat. That's a positive statement to someone who has high skill in basic science, clinical work, and teaching. So, Dr. Cellier, I'm very happy to see you remote.
Thank you. Thank you so much, Carol, for the nice tour, and thank you to the committee for inviting me. And good morning, America. I will talk on a very specific niche. I would say that's refractory patient. And I will more focus on our French experience of our network on that point. So these are my disclosure information. So, as you know, the gluten-free diet remains the only available and validated treatment for celiac disease. And the second point is that some very few patients had a severe complication, which is called EATL, for enteropathy associated T-cell lymphoma, which is a severe situation in some patients. Usually, the gluten-free diet may induce clinical and histological improvement in approximately 70% of the patients. However, we observe, mainly in adult patients, because I am adult gastroenterologist, that patients, despite a so-called gluten-free diet, had a persistent villus atrophy and also persistent symptoms. In this patient, we don't know for some of these patients if the adherence to the gluten-free diet is strict, if they have a slow response, if they are slow responder or what we call non-responsive celiac disease, but they also may have what we call refractory celiac disease. Refractory celiac disease is defined as a symptomatic persisting villus atrophy despite a gluten-free diet, a strict gluten-free diet. It's very rare, but it could be associated with a very high mortality and lacks a therapy. So when as a clinician, you are faced to a patient with villus atrophy refractory to a gluten-free diet. You have some steps to consider. The first one would be, is it really a celiac disorder? You have to check both HLA DQ2, DQ8, positivity of TTG antibodies or EME antibodies before the gluten-free diet. And the first main cause to refractory to a gluten-free diet is probably a poor observance of the diet. And for that, it has been shown this morning that you should send the patient to a dietitian. You should check the positivity or not of TTG and maybe some other urine or stool gluten detection of GIP, for example. Furthermore, there is some other disorder outside celiac disease that may mimic refractory celiac disease. I will not detail this point, but it could be common variable immunodeficiency, infection like Giardia lombriasis, tropical sprue, collagenous sprue, autoimmune enteropathy, and now we can discover more and more such patients in adults using NGS next generation sequencing. And also there is some drugs inducing villus atrophy, and the most common of these could be olmesartan as described by the Mayo Clinic group. Move on now to the refractory celiac disease. It's easy to make the diagnosis if you have a good team and good objective tools to use. There is two types of refractory celiac disease, the type 1 and the type 2. I will start by the type 2 because it's, for example, the most easy to make the diagnosis because we have objective tools, because in this patient we may show an aberrant intraepithelial lymphocytes component into the epithelium using immunohistochemistry, PCR, and flow. And we will discover an intracytoplasmic CD3, but the lack of surface marker of CD3 of CDX together with a clonal rearrangement. The best tool to show this abnormal population is flow cytometry. However, flow cytometry is not always available and time consuming and is not always done. And maybe in the future, the use of NKp46, it's a diagnostic marker, which in our hands, it could be replaced sometimes the use of cytometry, but it's not still available. Whatever this type 2 refractory celiac disease should be considered as a cryptic T-cell lymphoma, and we will say later that may induce severe complications. The type 1 refractory celiac disease is more difficult to diagnose because there is no abnormalities in the intraepithelial lymphocytes component. And as we know, half of those patients supposed to be having refractory celiac disease in the UK cohort, for example, are probably non-compliant patient because they had positive GIP test suggesting consuming gluten-free diet. So for the type 1, it's very difficult to make the diagnosis between type 1 non-responsive celiac disease or non-compliant celiac disease. Whatever, it's very important to have a good diagnosis at the beginning because as you can see, the survival is completely different between the two types of refractory celiac disease. The type 1 is more benign disorder, and the type 2 is a more severe disorder with a poor 5 years survival and a high risk of developing overt lymphoma. Move on now to what we did in France. We had done a French national network for complicated celiac disease, which called CELAC. It was granted by the French Cancer Institute for rare cancer. And since more than 10 years, we have reviewed and assess more than 1,000 patients referred to us for supposed complicated celiac disease patient. And what we have observed, we have diagnosed finally only 3% of patients with type 1 refractory celiac disease and 7% of patients with type 2 refractory celiac disease. So even in referral center is very rare. But this type 2 refractory celiac disease were responsible for half of the overt lymphoma referred to us. So what are the risk factors among supposed to be complicated celiac disease? What are the risk factors for developing refractory celiac disease type 2 or either? It's more male, more patient diagnosed after the age of 50 years old as a celiac, more patient with a poor adherence to the gluten-free diet, and patient with a more severe disorder than the diagnosis with severe hypoalbuminemia, weight loss, and diarrhea. One point should be noted is that no patient with diagnosed with celiac disease before in childhood, before the age of 18, had subsequently developed refractory celiac disease type 2 or overt lymphoma. For the patient who developed subsequently overt lymphoma after the diagnosis of refractory celiac disease type 2, it's approximately 30% of patients, but it's the main cause of mortality in this situation. As you can see is our slide, most of the patients developed overt T-cell lymphoma in the 3 years or 4 years after the diagnosis of refractory celiac disease type 2, but it could be later in some more rare cases. So for a clinician, what are the challenges for refractory celiac disease? The first should be for sure to consider and to confirm the diagnosis of refractory celiac disease using immunohistochemistry, molecular biology, and if possible, flow cytometry. The second point is before to treat the patient and to improve the clinical status and nutritional status, because most of these patients are usually in severe shape. So we use, for example, total parenteral nutrition or steroids using oral open capsule budesonide or IV budesonide. The third point would be to exclude ETOL, both at diagnosis but also during follow-ups. And the last point would be to cure the disease, but it's more difficult for the moment. In our experience, the diagnosis of refractory celiac disease would be in 3 main clinical presentations. The first one is the classical one, is a persisting venous atrophy despite a strict gluten-free diet. It's approximately 60% of the case. The second one is patient before the diagnosis of celiac disease, but in initial diagnosis before the gluten-free diet in patients with severe and complicated celiac disease. For example, patient developing celiac disease on ulcerative gingivititis or mesenteric cavitation, for example. And also one point, we discover refractory celiac disease after the diagnosis of intestinal T-cell lymphoma, revealing an underlying refractory celiac disease in 15% of cases. In this patient, we used to make a more complex radiological and endoscopical workup. And for endoscopy, we used to perform video capsule endoscopy to exclude, to search for ulcerative gingivitis, and in that case, to perform double balloon enteroscopy to make biopsy and such ulceration to exclude lymphoma. We use as a first line CT scan MRI to exclude mass, stenosis, and to check for hyposplenism and mesenteric cavitation, which is relatively frequent. One of the best tools to exclude or to rule out or to make the diagnosis of overt lymphoma associated with refractory celiac disease, as you can see on this slide, is the use of the PET in this patient, because if the PET is positive, the predictive positive value is very high, it's 100% in our experience. In the other hand, when it's negative, it's more reassuring, but it could be possible that we have observed 4 cases of patients with negative PET and also with a diagnosis of overt T-cell lymphoma. After that, the diagnosis of ETL in such refractory celiac disease patient could be very difficult, and surgery may be the key for the diagnosis, at least in more than 50% of cases, because we didn't add any histological diagnosis before to perform surgery. So surgery should be considered when you suspect lymphoma associated with refractory celiac disease type 2, for example, and you don't have the proof using endoscopy or radiological biopsy. Whatever, in our experience, the patient who will develop lymphoma are those with persistent subtotal or total villus atrophy after initial treatment with open capsule budesonide. And you can see that patients who do not respond initially to budesonide are those who have the highest risk to develop overt lymphoma. We try to find any tools to predict the progression to overt lymphoma, and we use NGS and so on, but it's not yet available. NGS could be used for finding a therapeutic strategy, for example, and we will see that later, the JAK inhibitor, for example, because we can see if there is a JAK mutation, we can use JAK inhibitor. Move on now to the treatment of this refractory celiac disease patient. The first step is clearly the use of open capsule budesonide, both in type 1 and type 2 patient, as described by the group of Joe Murray at Mayo Clinic. It seems very effective both for type 1 and type 2, but in our experience, we can have some failure or side effects, and probably more frequently in type 2 patients. In type 1, when there is failure using open capsule budesonide, we can use immunosuppressive drugs, anti-TNF, TOFA, other drugs, new drugs developing, and maybe Jocelyn will speak of that after. When we have failure of open capsule budesonide in type 2, we consider either autologous stem cell transplantation or now tofacitinib or maybe anti-IL-15, but is not easily available. We don't use immunosuppressive drug in such patients because we observe some progression to overt lymphoma when we use such drugs in type 2 refractory celiac disease. Regarding autologous stem cell transplantation, as you may see here, it's, in our experience, the only way to prevent the occurrence of overt lymphoma in the long term. The problem is that it's needed to be considered early in the disease because it's impossible to consider stem cell transplantation after the age of 60, 65. And furthermore, it needs a long term to show efficacy. And in our experience, we need at least 12 months because to see improvement in the clinical situation, so it could be a little bit long for the patient. Move on now to the future. In the future, based on the research lab from Nadine Serve and Bana, they have shown that patients with refractory celiac disease type 2 have an overexpression of IL-15, which is a cytokine increase in specifically in refractory type 2. And there is also JAK1 STAT3 gain mutation. And this could be useful to find a new therapeutic approach. It's why we try to use biotherapy using anti-IL-15 a few years ago, and we use IMJ 714, which is on bio anti-IL-15 antibodies, and we use it in a randomized control study compared to placebo. But the result after 3 months of treatment was not significant for the primary endpoint, which was the number of aberrant IL in type 2 refractory celiac disease. And we didn't observe any significant change in histology, despite we observed some improvement in clinical status, in diarrhea, and also in biomolecular, in chronality in these patients. Maybe the duration of the study was too short because 3 months is very short at the for this patient, and maybe the primary endpoint was not the good one because the number of IL is not maybe the clue of this disorder, because we observe, but I'm not sure it's significant, that when we follow the patient after this randomized trial at 5 years, we had 11 patients in our hospital, and those who were treated by anti-IL-15 seems to have better outcome than those who received placebo. But it's a very too short population to conclude anything. Actually, probably the most important thing and probably the most available drugs for this patient is tofacitinib, which is a JAK inhibitor used for ulcerative colitis. And in this patient, there is one short study published by the group of Amsterdam together with 2 patients from Berlin. And using tofacitinib, they observed clinical and histological improvement in 6 patients, but relapse after discontinuation, and 1 patient should have stem cell transplantation. We have a preliminary experience in France with 4 patients present and two with clinical improvement. So we need to have more longer term for this patient and longer follow-up for this patient. But it could be a clue, for example, between stem cell transplantation and could be used as a temporary treatment between to improve the clinical situation of this patient, and after to consider stem cell transplantation, for example. But it should be done in the future with more patients. Whatever it's my take-home message, the diagnosis of refractory celiac disease is very rare, but it's probably more frequent in what we call high-risk celiac disease patients. That means patients with a diagnosis of celiac disease after the age of 40 years old, and patients with a severe and unusual celiac disease presentation at diagnosis. That means ulcerative gingivititis, severe disease at diagnosis. In this patient, they should have stricter follow-up, and I think this patient should have repeated biopsy after after starting gluten-free diet every 2 or 3 years to see if there is any persisting villus atrophy. If there is alarm symptoms of persisting villus atrophy, probably we should consider to perform immunohistochemistry, biomolecular clonal TCR gamma gene rearrangement, and flow if there is any abnormality to consider the diagnosis of type 1 or type 2 refractory celiac disease. And I think also that these patients are very rare, but should probably refer, or at least their slides of histological slides, to referral center if there is any doubt for refractory celiac disease. But because if it's rare, it's very serious, and we need to have a referral center for this patient, given the rarity of the disorder. So I would like to thank you for your attention, and I would like to thank all people working in that network, that CELAC networks. And just a word in memoriam for my friends, Professor Jack Schmitz, who passed away a few weeks ago. He was a friend of Stefano Guandalini, and organized with me the Celiac International Symposium in Paris in 2002. So don't hesitate to contact us or to visit Paris. As you can see, the scene is clear and you can swim. Thank you.
Thank you very much, Dr. Cellier, for this very comprehensive overview of refractory celiac disease. So now we're gonna get insight into the other side of what we can do for those patients who do not heal on a gluten-free diet, and all celiac disease patients are large who have to follow a gluten-free diet and know that it can be a constraint. So it's my pleasure to welcome our next speaker, Dr. Jocelyn Sylvester. She's a co-director of the Celiac Disease Program and an attending physician in gastroenterology at the Boston Children's Hospital. She has also worked as an assistant professor of pediatrics at Harvard Medical School for 5 years. Her research interests include the diagnosis is the French accent, so we're following with the French accent, and management of celiac disease. And our talk is gonna tell us everything we need to know about where are we on the path to medication for celiac disease. So welcome, Jocelyn.
Thank you, Dr. Abney, and thank you very much for the opportunity to speak today. It's been a great meeting, and hopefully that will continue. These are my disclosures, which aren't really relevant because, to be honest, I'm a bit of an impatient person, and so I wanted to take the long view on this. And so if we go back in the archaeological record, there's a skeleton that was dated to 100 AD found in Italy from an 18 to 20-year-old that had signs of malnutrition. And they were able to get some DNA from this person and find that they were HLA-DQ 2.5. So they questioned whether or not this might actually be somebody who had malnutrition due to celiac disease. It actually wasn't until a few hundred years later, in 250, that Aretaeus of Cappadocia wrote what is considered to be the first written account of celiac disease. And then there was a period of the Dark Ages when there was isolation, loss of what we knew, and a lot of wheat consumption. And it wasn't really until the 19th century that celiac disease came to the forefront again. And it was Francis Adams in 1856 who found Aretaeus's book and translated it. And then a generation later, Samuel Guy, he actually made the first modern description of celiac disease. And he was actually more modern than maybe he realized. And he described it as a chronic indigestion in persons of all ages, yet it is especially apt to affect children between 1 and 5 years old. And so it was a little while, actually 100 years ago, when Sidney Haas in New York started pioneering his banana diet. And this was really a period where folks were trying to look at dietary elimination as a treatment for celiac disease. And one of the key figures in this was Wilhelm Dick, who actually was a Dutch pediatrician. And he was really one of the first clinical investigators in celiac disease. When he got his degree in 1928, the short-term mortality for celiac disease was between 10 and 25%. As we saw from the skeleton in the closet, it actually maybe is a little bit more if you look longer term, because malnutrition is a chronic condition. And really, it was the banana diet and then this Fanconi diet that was a little more liberal, around allowing fruits and vegetables. Others were focusing on the fact that because of fat malabsorption, these patients had steatorrhea, and so they may do better on a low-fat diet. The problem was that that became a very low-calorie diet, and so they actually didn't do as well as the ones who stuck to their bananas and their vegetables. And so what Dr. Dickey did, which was different, was he actually encouraged his patients to experiment with the gluten-free diet. And to be honest, I think this is what patients do with a gluten-free diet to this day. And from their reports and his careful observations, he recognized that it was actually wheat that's important. And this is often attributed to have happened during the Dutch famine during World War II, but that actually was sort of the trial that demonstrated what he'd already showed, which was that wheat was important. And he then subdivided wheat into different fractions and identified that actually, gliadin was important. And so on the right here, we have a picture from his thesis. This is an N=1 study, and it actually tells us a lot about clinical trials and how we're testing drugs for celiac disease today. And so this is a child, and this is their growth trajectory for height. You can see that they were falling off the projected curve, and they were admitted, and they started to get better. They discharged them home, and they did okay, and then they sort of plateaued for a bit. And this repeated. And then when the child was 8 years of age, they kept them in the hospital, but they let them go to school. And what they found was it was actually very easy to follow a gluten-free diet in the controlled setting of a hospital. But when you sent somebody out into society to follow a gluten-free diet, it was a little bit harder. And so this, again, shows the importance of diet and the difficulty of dietary therapies. It also demonstrates the importance of gluten in understanding whether or not something may be treating celiac disease. So that's where they were. And where are we now? So we're only in 2024. And to keep things in perspective, the first drug that was tested for celiac disease was first given to a human in 2005. So although it seems like a long time, that's actually less than 20 years. And this was something called larazotide acetate. And what this is it's a short protein, it's amino acid, it has only 8 units, and it's thought to be important in helping keep the intestinal cells together, because small proteins like fragments of gluten can go between the cells if they're not held tight. And it's thought that this helps keep them tight together, and then there's less permeability. And so that was how they tested the drug. And so in order to understand how we get to a drug, we need to understand the process. And there's a lot that happens before this drug even gets put into humans. And that's really clustered under the preclinical phase, which could be experiments with cells. It could be experiments with, gluten and an enzyme. It could be animal studies. It could be modeling things in the computer. And ultimately, the goal is to collect enough data to be able to go to the regulatory authority, whether it be Health Canada or the FDA or EMA. I'm going to talk about the FDA specifically, but they're all fairly similar, and present a portfolio of, this is my drug, this is how I think it works, this is what I've seen when I give it to animals, and this is why I think I should give this dose to humans, and this is how I plan to show that my drug works. And so once that's approved by the regulatory authority, then something called an IND, or an investigational new drug application, is approved. And this is permission to start experimenting in humans with this medication. And so for phase 1, there's usually 2 phases. The first one is to look at healthy volunteers. And usually this starts at doses that are much lower than what was thought to be effective, and much, much lower than what was thought to be toxic in the animals. And because safety is the primary concern, often the first person will finish the study before they'll let the second person enroll, so that they can maximize the data they get and make sure that nobody's being given the drug when maybe it's not such a good idea. The other important thing is not only to give people the drug, but to give them placebo, so that there's some comparison to know whether or not the effects seen can actually be attributed to the drug. And usually there's an ascending dose. And often the findings in these studies are organ-based and reflect what was seen in the animals. Now, the next phase is phase 1B, and this is when people with the actual disease get the drug. And in this particular study, instead of doing 1 dose, they actually brought people into the hospital for 3 days, gave them 3 doses On the second day, they also gave them a single dose of gluten. And so they looked at safety in celiac disease. And then they also, because they had people with the disease and because they were doing a gluten challenge, could start to get some data about whether or not it was doing what they thought it did. And so what they found was that there was no safety signal. So the adverse events were the same in the drug and the placebo group. And when they looked at intestinal permeability, which is how they think this drug works, the group that got the drug stayed the same through the study, whereas the one that got placebo, it increased, their guts became more leaky, suggesting that maybe the drug was doing what it was intended. They looked at immune activation and really didn't see anything. And they looked at symptoms, and there seemed to be a signal, but really the problem with these studies is that they're small. And so you really need to have a big effect in order for it to be significant. Nevertheless, this was encouraging, which was the green light to go to phase 2. And so this is the first phase 2 study for a drug in celiac disease. Most drugs don't make it to phase 2, and even fewer make it to phase 3. And so this is a larger study. There's 9 centers, there's more patients, nearly 100. And this is a fairly classic clinical trial design. So there's a screening period, making sure that the patient is the right patient for the trial. Sometimes that involves blood work, sometimes it involves an endoscopy for celiac disease. And then there's a treatment period where, and it's usually blinded and it's usually randomized, meaning that neither the participant nor the investigators, and usually the people analyzing the data, know who got the drug and who got the placebo. And then after that treatment period, there's often a monitoring period. And so in this study, they had a lot of treatment groups. And the reason for this is that celiac disease is somewhat unique in that drugs are being tested in people who are already on another treatment. And that just makes it more complicated. And so the design is really important because controls are really important. So actually the first 3 groups in this study were all controls. So everybody in the study was on a gluten-free diet for the duration of the study. And one group, they stayed on the gluten-free diet and then they got the gluten challenge to see how the gluten challenge affected people. Another group only had the gluten-free diet as a sort of absolute control. Another group had the gluten-free diet and then got the highest dose of the drug to look at safety. And then the other groups got the gluten challenge and then increasing doses of the drug. And so what they found in this study was that on the left, you see the data for intestinal permeability, so what's the leakiness, and on the right, you see data for symptoms. And there's no clear pattern on the left. These are the error bars. And so there's a lot of variability, which makes it hard to make conclusions and suggests that probably intestinal permeability is not a very good measurement, and that's borne out in future trials. The other thing they did is look at symptoms, and you can see that the folks who only had a gluten-free diet, there was no change in their symptoms, which is good. Those who had only the drug maybe had an improvement, although the error crosses no change. Those who only got gluten definitely had an increase in symptoms. And then there is an unclear pattern with different doses of the drug. So maybe a signal, maybe not, but there's another way to look at this data that's also important. And that is what happened to the groups over the course of the study. So on the top, the solid line, this is the group that only got the gluten challenge. And you can see that they gave enough gluten to give people symptoms, which is really important, because if you don't give enough gluten to give symptoms, then you won't see a difference because there's not enough gluten, even if the drug works. And then they saw if they gave people gluten plus the drug, that the symptoms were attenuated, but they still increased. And what was interesting and maybe the most important finding was if you look at this group that was on the gluten-free diet, it looks like they improved. And this is the p-value suggesting this is actually a significant improvement. And all that these people had was they got enrolled in a trial and they took placebo drug and placebo gluten. And this is a really important finding because it tells us something about the gluten-free diet, which is that the gluten-free diet is adjustable. And so folks can decide how much gluten they're having based upon how important it is to have symptoms or not to have symptoms. It also showed that the gluten challenge worked, and we saw that we need a better biomarker. So this was a green light to go on to the next phase. And so they did another larger phase 2b study And this time they tried to learn from the previous study. And so you'll see we have the 14-day screening period. They made it a little bit shorter. We have the treatment period that's double blind, and we have a follow-up period, but there's this extra period added in here. And this is a single blind run-in period. And so this is when people are enrolled in the study and they keep on their gluten-free diet and they get placebo drug and they get placebo gluten. And the idea here is to try and accommodate for some of that effect of people knowing they're in a trial and knowing people are watching them, so they watch their own gluten-free diet a little more closely. And then they had the gluten-free diet with gluten challenge arm, and then adding 3 different concentrations of the drug. And again, they got mixed results. So on the left, again, you have intestinal permeability, and on the right, you have symptoms. And usually you would like to see that the drug separated from the group that only got the gluten challenge. And that didn't really happen for intestinal permeability, although, and it overlapped, but maybe there was a signal for symptoms. What was interesting was that the group that got the lowest dose actually responded better than the groups who got the other 2 doses. So based on this, they thought, well, maybe we need to do another study, and let's not try and give people symptoms. Let's take people who already have symptoms, which is a different study population now. So initially, we're taking people with celiac disease and trying to prevent a response to gluten. Now we're taking people who think they're on a gluten-free diet, but still have symptoms to see if the drug will help them. So this is really a true adjunct to a gluten-free diet. And again, there's a placebo run-in, there's placebo group, there's different doses of drug, and then there's an observation afterwards. And you can see clearly here again in the run-in phase, this is symptoms. And so symptoms decrease during the run-in as we expect. This is the 4-week period where people are still getting better. And then this is when the treatment starts, and there's no gluten in this study because the sort of inherent assumption is that people are having symptoms because they have gluten. And you can see that there's the different groups, which again show that pattern where the lowest dose actually seemed to have the lowest symptoms. And the highest group actually performed worse than no drug at all. So based on this, they decided to go through with a phase 3 study, which is the last phase. And the point of phase 3 is, all right, in phase 2, we figured out that the people who maybe benefit from the drug are those with ongoing symptoms on a gluten-free diet. But we need lots of people to really be certain that this is going to be an effect. And based on that earlier trial, let's put the dose a little bit lower because those higher doses really didn't seem to be working. And in this particular trial, they looked at symptoms because that's what you need to get a drug approved in the United States generally, specifically abdominal pain. And they needed almost 1,000 patients. And they recruited over half of those patients. And then they announced that they were halting the trial. And they weren't halting the trial because the drug didn't work. They were halting the trial because those error bars that we were looking at, in order for the drug to work, the error bars can't overlap. And they realized that because of the size of the error bars and the size of the difference, they were going to need to recruit maybe even 2,000 people to show a difference, which then makes the trial get twice as expensive. And at some point, it's just not financially viable. And so that was why they decided to stop the trial. So what did it take to get to phase 3? You can see these are the different trials, and we didn't talk about every single one of them, that there were different doses. And as they went through, the trials got longer. And this is maybe the human side of it. And so for these trials, they enrolled participants, they had gluten, and they had a treatment phase, and then they were in the trial for a period of time. This one here is a question mark because it wasn't reported. And so what does that mean? So in order to get to phase 3, so this is only phases 1 and 2, there were 141 study sites that were started up, more than 1,300 patients who were screened, more than 900 who were enrolled, and 800 who were randomized. Sorry, 755 who were randomized. And if you look at how much time in the trial that is for the patients, it's 119 years of people time being on a drug and 161 years of being in a trial. And so this is not a small undertaking, which is part of the reason why it takes time. And money, most importantly. And so here's a summary of the approval process. Phase 1, as we saw, was safety, usually smaller studies, usually less expensive. Phase 2 starts to get a little bit more expensive, larger studies, more sites. And then phase 3 is much larger, and these are the actual median prices. It's not unusual for phase 3 to cost $1 billion or more. So it's a significant investment to get something to the finish line and get approved. And then even after drugs are approved, sometimes they monitor them as well. So what about another treatment for celiac disease? Because there's different strategies. And one of the strategies that's maybe the most exciting is we know a lot about celiac disease, and we know that T cells are important, and we know that it's an immune disease. So instead of targeting the intestine, can we target the immune system? And so this was the idea behind NextVax, which was a tolerogenic therapy, which was a subcutaneous injection of peptides, which was called a vaccine. And the hope was that by giving patients with celiac disease peptides that they recognized in a way that would make them think the peptides were safe, that they then would not react when they got them orally. Now, one of the reasons we do studies is to find things out. And this was actually a very exciting study because we found out some unexpected things. And so there were 2 centers in the first study, and they did, like we saw for lorazepam, the single ascending dose. And they looked at safety and tolerability, and then they also looked at T cell responses and biopsy. But what they found that was really interesting was that they were giving these peptides under the skin, and the patients were getting the same symptoms that they would get if they ate gluten. And this was really something that highlighted the fact that although we think of it as an intestinal disease, although we think of intestinal symptoms, these T cells that recognize gluten are very important, and they circulate. They hang out in the intestine, but they circulate through the blood, and you can find them in different areas of the body. And that the immediate symptoms are probably more related to what these cells are doing than to damage to the intestine, because we know that takes longer. And so one of the things they did was they had those gluten challenges, and they tried to measure the T cells, and they found that the T cells were spitting out something called IL-2, which is a signal for more T cells to grow after they were exposed to gluten. And so that raises the question, which I think Dr. Tydin is going to address next, which is cytokine release after gluten exposure a good biomarker? Because we know lactulose mannitol is not a good biomarker. We know that it's prohibitively expensive to do a clinical trial and do 2 biopsies on 1,000 people, and we need something better. And so we had done some work on this with our group in Boston in what's called a phase 0 study. And so this is a study just to look at biomarkers where there's not actually a drug. And so these are some of the bravest volunteers for celiac disease, I think, because what they do is they come and they get randomized to have 2 different doses of gluten with no drug, just because they're helping us figure out, well, how can we see how the body reacts to gluten? And is there something we can look at on an earlier time scale? And so there were 2 doses, and we saw that symptoms occurred with both doses. But when we looked at some of the immunological markers, and when we looked at damage, it was only significant with the higher dose. But we know that to put people in clinical trials, we want lower doses of gluten. And so one of the things we did in this study was we looked at this short-term IL-2 release. And so this is the serum IL-2 values for the 2 groups, the 3-gram group on the left, the 10-gram group on the right. They were on a gluten-free diet until they started the gluten challenge on day 1. And we measured 4 hours later their IL-2 levels, and you can see that it went up. Oh, sorry, going the wrong way. It went up in both groups, and this is a logarithmic scale, so it went up very significantly. And because we had all those other markers, we could show that IL-2 actually correlated very nicely with some of our markers in the intestine of histology and with symptoms. And so that's potentially a biomarker that can be used for the pipeline. And so right now, these are the drugs that are in development for celiac disease. And I think what's exciting is that there's lots of them. They have different mechanisms. And as you can see, they're sponsored by different companies, which means lots of people are interested. Now, what's important is that this is not going to be easy, and it can't be done without patience. So I've added some columns to this table showing when these trials started recruiting and how many patients they want to get. And so you can see this is only phase 1 and 2, and we're looking at thousands of patients, and there's going to be even more patients who are screened. So we can't get to a drug without volunteers and without a lot of people and a lot of investors and a lot of scientists all working together. And I'll stop there. Thank you.
Thank you. Thank you, Dr. Sylvester, for that talk and update on where we are with medications. It sounds like we're still in the infancy state. Let's go to our next speaker. This is a pre-recorded talk by Dr. Jason Tydine. He is an associate professor at the Walter and Eliza Hall Institute of Medical Research in Melbourne, Australia. And he is a gastroenterologist with expertise in the management of celiac disease. He's going to speak to understanding cytokines and celiac disease.
If you want to start with any questions, I'm sure that Jocelyn and Christophe can join as well.
There was one question about the risk of intestinal cancer in celiac patients, not in refractory patients. And that answer, maybe Dr. Cellier can chime in on this, but my understanding is we talk about a small increased risk of all GI cancers, but in the latest, and I don't know if Dr. Lebwell's here, I think
Dr. Lebwell had to leave.
Yeah, I think the bottom line is that these numbers are changing depending on where the study comes from, number one. But I think overall, there's overall agreement that lymphoproliferative cancers are much more common, meaning sixfold maybe. And the other GI cancers are a lot less common, but now pancreas is coming out and esophagus is risk, but not colon cancer. Colon cancer in the past, we said was a risk. So these are very hard studies because they're populations in the United States we didn't diagnose for years on end. We had a lot of undiagnosed patients, and we don't know if that makes them at a higher risk for cancer later in life. And now we diagnose earlier, so in the well-treated celiac, I'm not sure what the answer is. But practically speaking, colon cancer is the one you can screen for. And so that clearly should be done in a timely manner in celiac patients by colonoscopy, not by other testing. I think they should, as a risk patient, potential risk patient, get a colonoscopy.
So is there something that, Dr. Cellier is on as well, so perhaps your expertise, Dr. Cellier.
Yeah, I don't know if you hear me. It's the same answer. Maybe there is a small higher risk of small bowel adenocarcinoma. I am not sure it's clearly significant because we have observed in our experience, we have few small bowel adenocarcinoma outside refractory celiac disease. I mean, it's a possibility probably because of chronic inflammation in the small bowel, like in Crohn's disease, for example. But regarding the other cancer, except for lymphoproliferation, probably associated with the persistence of villus atrophy outside refractory celiac disease, we have no specific signal.
I guess a question from being a pediatric gastroenterologist, would you say there's a higher risk if someone, is the length of time that you've been diagnosed, and I guess we don't know how often you get exposed in that sort of phase, is that something that there are some studies or some thoughts, even if there are no studies, some thoughts in terms of malignancies and risks?
I've show that in my slides. In our cohort of patients, we have no patient no pediatrician patient, no celiac disease patient diagnosed during childhood who subsequently developed overt lymphoma or type 2 refractory celiac disease. So it's probably a good point. I don't know if it's different disorders or maybe the fact to be diagnosed early in childhood, they are on more on a gluten-free diet, but we didn't observe any lymphoproliferative disorder in this pediatric diagnostic patient.
Thank
So
you.
it's a good point
Thank you.
for early
is the vi-
diagnosis.
Is the video ready now, or?
I think we're doing the Q&A, and
Oh,
we'll move to Jason Tiding talk after the Q&A, so we can keep on going with the question that were pressed in the chat. So there's one about drugs, probably for Dr. Sylvester. That do we have any drug that are in phase 3? So basically, they're ready to go, right?
Not now.
That was
Short
too
and
quick an answer. That was too
But you
quick an
got to go through phase
answer.
1, and we've got lots in phase 2, and that's how you get to phase 3.
So what's in the horizon that we can say, oh my God, okay, maybe heading to phase 3? What do you think, Jocelyn?
So I think there's sort of a few different like key approaches. One is enzymes, which are sort of a little bit stalled. There was a phase 3 for an enzyme, but that ended. Another is to look at some of these tolerogenic drugs, which are the drugs that are trying to change the immune response. And some of these are in phase 2 trials. And then some of the other phase 2 trials are looking at repurposing drugs that have already been approved for other conditions in order to get an indication for celiac disease.
and there's a question, Jocelyn, about non-immunogenic wheat strain for human consumption. Is there anyone developing or working on that?
Yes, there is. And that's a very interesting area because it's a food, it's not a drug. And so it actually doesn't go through the same process to come to market as a drug would. At the recent celiac meeting in Sheffield in September, there was a talk about this. And what's super interesting was that they'd taken out some of the gluten genes, which we think are important because they help things stick together and give better quality. But they found the ones where they deleted the gluten genes, the quality of the bread they made was actually rated better. And so I think that's a hopeful sign for this approach.
So maybe to enlarge the discussion, and because I'm a basic scientist, so one of my questions, and that's for everybody who wants to jump in, would be like, what do you think we still need to learn or understand, about why people are not living on a gluten-free diet that could help the development of a drug or medication that would work for celiac disease?
Well, I think the number one thing is prevention is better than cure. And so knowing what it is that triggers celiac disease in the first place, because most people who have celiac disease, who could get celiac disease, don't, and having a way to intervene, that's where I'm really hopeful that there will be some developments, and I suspect those will come from the lab. I think when we show, and I purposely did not show any cartoons of what the thought of mechanism of celiac disease is, because they're cartoons, because there's some gaps. And so I think we really need to have a better idea of what's happening at the tissue level when celiac disease gets activated.
I have, Christoph, I have a quick question for you about refractory celiac disease and other genes. Is anyone identified select gene mutations? I know you talked about the JAK or the JAK2, some have it, but is there any panel of genetic testing to look at the other immune sort of vulnerable areas that might predispose them to either ongoing inflammation or cancers?
I'm not sure because we used it's not me, but because we did NGS in this patient first for the diagnosis to exclude, for example, other autoimmune disorder, for example, CTL4, CATL-A4, a mutation, for example, or autoimmune enteropathy. It's very rare, but it could be. And the second point, maybe to find some mutations that may guide the treatment. For example, in most of our type 2 refractory celiac disease, we observed JAK1 mutation. It was maybe the use of tofacitinib or other JAK inhibitor could be useful.
Yeah, thanks.
We have a few more questions in the chat. So that for Jocelyn, so how effective are gluten detectors such as the NEMA sensor? That's one of them.
That's a great question. And I think your institution and my institution are imminently going to be enrolling in patients for a clinical trial to answer this question, because it's a question that we need the answer to. And that's another important thing about clinical trials, is that they're not just for drugs. And so I think there's some data to show that it can see gluten. I think the problem is the demands of what we're asking it to do and what detection can do in terms of wanting to have a threshold versus gluten, yes, no, and the complications of measuring food. So I'm very excited to see what the outcome of the trial is. My understanding is that it's not currently available, and so it's the other gluten detector technologies that don't look at food but look at stool and urine that are actually available, and so those are the ones that we're using in our trial. I should clarify, and Dr. Lebwall's running it.
So there is another one about more the drugs and the medication. So from Fernando Valerio from Brazil, that he said that in a study conducted by Beyond Celiac, the main goal of using the medication was intestinal healing. In Brazil, patients mainly think about not having to worry about cross-contamination with gluten and improving the quality of life. So what do you think? That's always a, what do you think about this? He asked, like, in terms of, do you want to heal patient or do you want to make their life easier, basically, and better?
And I think that's a debate, and a very active debate, because there's no direct way that people's enteropathy makes them sad, but not being able to eat gluten often does. And so I think probably the halfway house is, if something can allow people to eat more gluten and not get worse, that's probably a success, but that's a controversial point. Obviously, the goal would be to have something that heals the villi and allows people to eat lots of gluten.
And, we had conversations in the first session was really looking at what do you look at as endpoints? Is it mucosal healing? And do we know the significance? So maybe learning more about the natural history of healing of mucosal recovery might be one of the things that we all need to get involved with from a clinical trial standpoint. And currently, we know that at least in pediatrics, it's not a routine that there's a repeat biopsy done. So I do think that at this point, it's kind of hard to answer that question, but would love to hear from the adult GI colleagues as well. Mucosal healing, yes or no? I know we do that in IBD, we knew that in EOE, but where are we with celiac?
That's what we're doing at the University of Chicago at the moment. As you know, we have a study to exactly examine this point, where we have patients that are active celiac disease patients that are recruited and placed on a gluten-free diet, and that we're going to monitor over a year period to try to understand really what determines whether a patient is going to heal on the gluten-free diet or not. So hopefully in a couple of years at the next ongoing CME, we're going to have some answer, to try to understand this heterogeneity in healing, and that hopefully are going to help, tailor the treatment also for those patients.
And sorry, go ahead. I was going to say, I think it really depends on tools, because, I talked about the first trials and lactulose mannitol ratio and permeability, which is getting people to eat 2 sugars and then measuring them in their urine and trying to use the ratio to guess how healthy their intestine is, which is different than trying to take a very small piece of a very large organ And so I think part of the problem we have is the precision of our endpoints is not very good and it's not very specific. And that's why I think we'll hear from Dr. Tydin about trying to make these endpoints more specific. And I think that tool will help us start to answer some of these questions.
Yeah, so I think it's very important in the future to combine, all the knowledge we have, as you were mentioning, the biomarker in periphery that Dr. Tydin is implementing, more fundamental knowledge we can get of how the intestine heal, and really combine all our forces to really try to really define, the best way of and defining the best tool for those patients. So there's one last question in the chat, maybe because I think we're running out of time. That's a bit different. Is there any connection between fatty liver disease and celiac diet?
So it's a gluten-free diet.
So I would say, or gluten, or the impact of gluten on fatty liver disease. I would maybe read it that way.
Well, I think that one of the things about the modern gluten-free diet, if you compare it to 2005, when TTG was really just becoming mainstream and gluten-free products weren't available, is that now one can eat a very unhealthy gluten-free diet. And so I think from what we know about fatty liver disease, the quality of the foods we eat and the content of them can drive the disease a lot more so, and that's often sugars and not proteins. So I think it depends what type of gluten-free diet you're eating.
But is there actually a proven association between the development of fatty liver disease in celiac disease patients on a gluten-free diet?
No.
Not at the moment.
No.
But when you make people absorb better, they often gain weight.
Yeah.
And increased weight is the #1 risk factor for fatty liver.
Right. But there's not an association, just having celiac disease doesn't have a high association with fatty liver.
No,
The
that was
predisposition to form it or not form it.
No, that was not the point. It's like whether, following an imbalanced diet can lead in these patients
Yeah.
with celiac disease, that following gluten-free diet can lead to fatty liver disease. That's I think it's more in that
Right.
sense.
But even with people who have gained weight, some don't get fatty liver at all and some do. So there's still something else about what predisposes you to develop a fatty liver. And so far, there's no relationship between celiac and just the propensity to develop a fatty liver if you ate high-fat foods or gained weight or did all this stuff, as far as I know.
Some patients may eat more sugar foods also when they stop gluten-free diet, or they make a gluten-free diet.
I think one of the conversations that we had in our first session was really talking about cutting down on a lot of, processed foods. And so I don't know if somebody is thinking about elevated BMI and on a gluten-free diet, but all depends on, as Jocelyn mentioned, the absorption increases. And then if you're eating not a healthy gluten-free diet, then of course, we all get into trouble, but that would not necessarily just be from a celiac standpoint. It's what you're doing with your diet would be important. So I don't know. Are we ready for Dr. Tydin?
I think so.
We are. Yes, we are. So I want to thank Dr. Cillier and Dr. Sylvester again, as well as Dr. Semrad and Dr. Abedi and Dr. Verma for that thoughtful Q&A. And we're always ready to be flexible. So we are going to wrap this session with Dr. Tydin's talk. And we'll be back with final announcements. But thank you so much to our speakers previously, and we're going to let the video roll.
Oh, okay, I'll count from 10 now. So hi, everyone. It's a real pleasure to be able to talk to you today, and I'm very sorry I couldn't be with you all in person. So as you've heard, I'm Dr. Jason Tydin. I'm a gastroenterologist and a celiac disease researcher. So this is my disclosure information. Most of this relates to consulting for a range of industry partners developing novel therapies for celiac disease. So today I'm going to be talking about the role of cytokines in celiac disease and how we might leverage this information to improve clinical care of our patients. So really, what are the goals? What are the goals of what we're trying to achieve in treating celiac disease? And I know that earlier today you would have heard a lot about the gluten-free diet and the challenges of the gluten-free diet and the outcomes. And so this slide really summarizes what happens after a patient with celiac disease is diagnosed. Clearly, they will start a gluten-free diet in order to try to minimize the immune mediated inflammation. And really, the goal here is to lead to mucosal healing of the small bowel, resolving their symptoms, improving their quality of life, and limiting some of the longer-term complications resulting from ongoing gluten exposure. And so some of the key goals in this is to firstly make the diagnosis of celiac disease. We want to be able to monitor gluten-free dietary adherence. And importantly, we want to be able to assess mucosal healing. Now, whilst these are very important goals, we do have challenges with achieving each of those objectives. So we know that current diagnosis of celiac disease is suboptimal, with, depending on the country, probably 50 to 80% of people with celiac disease remaining undiagnosed. We know current diagnostics that rely on celiac serology and small bowel histology only work when people are consistently and actively consuming gluten. The gluten-free diet, as you've heard, is lifelong, strict and onerous. And even when people try their very best to be strict with the gluten-free diet, many don't achieve full symptom remission, and many people have ongoing enteropathy, presumably related to sensitivity to very low levels of gluten exposure. And monitoring their adherence to a gluten-free diet can be very challenging, as there's really no practically implementable objective way, whilst we utilize dietitian and other surveys as ways to monitor this. Objective ways such as gluten immunogenic peptide assessment isn't still quite yet ready for prime time in the clinic. So there's definite needs for all of these issues, and we really need to develop better ways to diagnose celiac disease, monitor the diet, and ultimately develop better therapeutics. So how can we do that? And so this is where we can start to talk about celiac disease biology and the immunology behind the development of disease. And I know that Dr. Valerie Abadie will be talking in more detail about this during today's session, so I won't belabor the point, except to say that T cells are very important in celiac disease biology. And in particular, on the left, you'll see a diagram showing the central role of the gluten-specific CD4 T cell. And this is a T cell that is pro-inflammatory, releasing a range of cytokines. So the cytokines are these small molecules that are small proteins that mediate a lot of functions in the immune system, and they tend to bind with receptors on a range of cell surfaces. So there's a range of pro-inflammatory cytokines, such as interferon gamma. And you can see in the picture on the left at the bottom, the T cell expresses a range of markers there that show that these are activated and express these pro-inflammatory molecules. And this orchestrates some of the subsequent events that leads to damage. This includes the activation of CD8 T cells and gamma delta T cells, which are in the intraepithelial lining, and this is depicted in the central figure. And the activation of these cells leads to natural killer-like functions in these intraepithelial lymphocytes that lead to ultimate damage into the small intestine. And then on the right, you can see that there's interactions between the T cells and B cells, and T cells provide help to B cells to produce antibodies to both transglutaminase and to gluten. And obviously we use antibodies as a useful tool in the diagnosis of celiac disease. We also see that B cells provide help back to T cells and amplify the T cell response. So that's a two-way street. So you can see here that gluten-specific T cells on the left there are very important for the events that occur in celiac disease. And when we do studies on the mucosa of people with chronic disease, we can see that there's a range of inflammatory cytokines detectable, for example, interferon gamma. You can see those listed there. And when we challenge people with celiac disease with gluten, there's a range of other cytokines that have been demonstrated, including interleukin-8, TNF-alpha, and interleukin-2. So could cytokines, the detection of these small proteins, be a way to detect the gluten-specific T cell and provide a window into the biology of celiac disease? Well, we've actually gotten some very interesting data recently from actually a clinical trial of a novel therapy for celiac disease, which was called NextVax-2. And this particular therapeutic was composed of 3 peptides that were strong T cell triggers to activate the gluten-specific T cell with the goal of inducing immune tolerance to gluten. Unfortunately, this therapeutic did not achieve its primary endpoint. But what was learnt during this trial is when people with celiac disease were injected with these gluten peptides, they developed quite a striking and characteristic immune signal in their bloodstream. And you can see on the left there that people who received that injection of therapeutic within 2 to 6 hours had an increase in a range of cytokines. The one at the very top there is interleukin-2. Just highlighting that with the arrow, but there's also others such as interleukin-8, MCP1, IL-10 as well. But people who received placebo, nothing happened. And interestingly, the elevation of these cytokines correlated with the symptoms people got to the injection of gluten, which triggered a range of symptoms such as vomiting, nausea, diarrhea, and abdominal pain. And this finding was quite striking and really was made possible by the use of ultrasensitive cytokine detection technology. So this was a very first. And we and others went on to really explore what happens if a person with celiac disease actually consumes some gluten. And the answer is something very similar. In other words, when people with celiac disease on a gluten-free diet consume a small amount of gluten and you take their blood, within hours there's this elevation in cytokines in their bloodstream, again dominated by interleukin-2. And you can see this in these pictures here. But also a range of other cytokines are elevated. Most of these cytokines come from T cells, but not all of them. Some of them come from a range of other epithelial cells, for example. And again, the height of the elevation of interleukin-2 correlated strongly with the severity of symptoms people develop. So you can see here in this figure on the left, the higher the IL-2, the more likely the person was to be vomiting with consuming gluten. And there's been a subsequent study performed by Dr. Leonard and Sylvester. So you'll hear Jocelyn be speaking in today's session. And this compared the interleukin-2 readout after a single dose of gluten to more traditional markers of gluten exposure, such as histology, serology, and some of the other immune readouts, and did show that this interleukin-2 marker was the first one to come up at 4 hours and was very, very sensitive, particularly at low doses of gluten exposure. And what we've shown in a series of studies exploring the role of interleukin-2 is that it's really useful as a diagnostic tool for celiac disease. And the study on the left looked at people without celiac disease and compared them to people with celiac disease and showed that if you don't have celiac disease, you don't get an interleukin-2 elevation after gluten. And the figure on the right shows a similar sort of thing, but instead of comparing celiac disease with healthy controls, it compared it to people with self-reported gluten sensitivity. These were people without celiac disease, but who were following a gluten-free diet because it made them feel better. And you can see, once again, strong elevations in people with celiac disease and really not much happening in those with gluten sensitivity. This one individual who did elevate, we wondered if she did have celiac disease, but she was unable to tolerate a gluten challenge for long enough the 6 weeks or longer required to get small bowel histology as a diagnostic tool. So we weren't able to confirm celiac disease. And similarly, in this group of celiacs, there were 2 people who did not elevate their interleukin-2 that we then took back into the clinic to rework up, and we showed that they actually did not have celiac disease, and that the villus atrophy that they had many years prior that led to their celiac diagnosis was not caused by celiac disease, but something else. So this was a really interesting set of findings. And we've subsequently been involved in refining this tool and converting it into a whole blood assay that does not require people to consume gluten at all. And in fact, what you do is you mix a person's blood sample with gluten in the test tube and then measure for interleukin-2 the following day after it's incubated for 24 hours. So a similar concept to quantiferon gold to assess for tuberculosis, where you put blood into a tube that contains some components of tuberculosis. So this was a very interesting approach that meant that essentially people did not need to gluten challenge because we were doing it in a test tube. So we've now got a platform to assess the gluten-specific T cell, because we know that this interleukin-2 comes from the gluten-specific T cell. And we've done work that I haven't showed you today that confirms that the source of the interleukin-2 that we see in the blood is, in fact, that pathogenic cell, the gluten-specific T cell. So can this work as a diagnostic tool? So this is the in-tube gluten challenge approach, the whole blood assay. And we've now completed a community study to look at its performance, comparing people with treated celiac disease on a gluten-free diet, people with active disease, in other words, they have not yet started a gluten-free diet, healthy controls without celiac, and non-celiac gluten-sensitive patients. And you can see here, this is an arbitrary cutoff of 2. And you can see here that the majority of people with treated celiac disease were above the line, as were those with active disease, and the majority of people without celiac disease were below the line. There are a few people on either side there that we're looking into further to characterize whether these people have been misdiagnosed or whatever. So this is still some ongoing follow-up. Some of these people had the less common genotype, the HLA-DQ8 genotype for celiac disease. And this makes sense because in the tube, we have a mixture of peptides, and the peptides that are recognized by patients with this less common HLA genotype are less well defined. So it's possible that in the future, newer formulations might be even more sensitive. But this was very impressive because, as you would recall, current diagnostics would not work at all in this cohort of patients because all of these patients had negative celiac antibodies. They have a normal transglutaminase because they are on a gluten-free diet. So this assay is able to detect the gluten-specific T cell that defines the presence of celiac disease, even when people are not consuming gluten. And so far, the performance of this assay is very promising, with an AUC of 0.94, a sensitivity of 90% and specificity of 97%. And we were able to achieve those figures by also incorporating a slight absolute level of interleukin-2 cutoff. And in the HLA-DQ8 celiac disease, the sensitivity was lower. So that does need some work. But mind you, this proportion of people with DQ8 celiac disease is around, is under 10%. So it's not the majority of patients. So very promising results as a diagnostic tool. Now, what else can we use this cytokine measure for to help us? Well, we can use it in clinical trials. It can be used to support a celiac disease diagnosis, which is clearly important when you're trying to recruit celiacs for a trial. As I've talked about, it's a biomarker for gluten-induced symptoms. And importantly, it can be used to assess drug efficacy, because if we can now assess and monitor the gluten-specific T cell, we can tell if a drug is working or not by tracking the interleukin-2 production. And indeed, this is already being used in a range of clinical studies. For example, this study by Joe Murray et al. Assessing a particular immune therapeutic drug that was being tested. So it's proving to be a useful tool to assess drug efficacy. And It can help stratify patients by their symptomatology and their interleukin-2 production. And in the future, I think symptom measures, these are patient-reported outcome measures, which we record patient symptoms, are very subjective, but we can introduce an objective component by linking symptoms to the interleukin-2 readout. And finally, the whole blood assay, which is the gluten challenge in the test tube, may be a way for us to track T cells over time. For example, the durability of a therapeutic without getting people to keep eating gluten. And this is really important for clinical trials. We don't want to feed people gluten all the time because that's not what people want to do. They're going to be feeling sick and it's very off-putting. So if we can do studies to assess their immune responses without asking them to eat gluten, then that will be a massive benefit for the conduct of clinical trials and getting people to get involved. Interestingly, we've also shown the link to symptomatology, and here is the data where the higher the interleukin-2 after a gluten challenge, the more likely the person is to vomit. I've discussed that before. We've looked at tetramers, so these are tools that detect the frequency of the gluten-specific T cells, and not surprisingly, those people who vomit do have a higher frequency of T cells. And this is with the whole blood assay. And again, we can see a difference between those who do vomit and those who don't. This person was high, even though they were not a vomiter. They had, I think it was lethargy that was extreme and severe that was recorded as their severe symptoms. So it still correlates with symptoms, and it's not just vomiting that it correlates with. But what is striking is that this result was before the person ate gluten. They didn't need to eat gluten. So in other words, you could predict whether a celiac might vomit to gluten or have severe symptoms based on their level of interleukin-2 produced in a test tube that was filled with some gluten. So this was a useful way potentially to stratify if a person would be highly symptomatic or not. Okay, so as a research tool, we've been utilizing the interleukin-2 cytokine platform to understand more about celiac disease biology. So we've conducted a study looking at the safety of oats that some of you may have heard about. This is hopefully will be published soon, this data. And we've recently completed a study called the Microgluten Challenge Study. You all know about the 20 parts per million defining the labeling threshold of the safety threshold for gluten in most parts of the world, although in Australia and New Zealand we adopted no detectable threshold for gluten, so it's very different. And I think the data informing on what is the safe threshold for gluten is very sparse, and really only one randomized controlled trial of 39 patients in total. So we've just completed a study with 51 patients using the IL-2 readout to define a lower level of gluten that activates the immune responses in people with celiac disease. And that work is being prepared for publication, but it does set the scene now for establishing a revised threshold. And this is important because we really need to make sure that the gluten-free standard is suitable to achieve the best possible outcomes for all our patients with celiac disease. And this tool is also useful for understanding the types of peptides that drive the T cells, understanding more about symptoms. We're very interested in understanding how does the interleukin-2 trigger the events that lead to things like vomiting and diarrhea and tummy pain. And in the future, I think this is a platform that will also be expanded to a range of other diseases, diagnostics in COVID-19 or other viral diseases, in cancer, in food allergy, and even transplant biology. So this is a really exciting cytokine-driven platform that could help with other conditions. I touched on research to understand symptom mechanism. We do believe that between gluten and the symptoms that people experience, there's likely to be these cytokines that are produced that activate some sort of downstream mediators, such as serotonin, that mediate the symptoms. And this is research underway at the moment. So just to finish, cytokines can really inform at a very translational level the care of patients with celiac disease, supporting a novel diagnostic, supporting better clinical trials of novel therapies for celiac disease to hopefully lead to better treatments. And I suppose monitoring is something that I haven't touched on. And basically, this is from a very nice review from Jocelyn Sylvester that was recently published, showing that with gluten, there's activation of the gluten-specific T cell, a range of downstream events that lead to the gut damage and the symptomatology. So can we use this gluten-specific T cell to monitor disease? Well, this was a very interesting study by colleagues in Oslo, where they showed when people with celiac went on a gluten-free diet, you can see that their celiac serology normalizes over 12 months. And these gluten-specific T cells in the bloodstream also drop down. There is a reduction in their gut gluten-specific T cells, and the gut mucosa heals up. So there is a tracking of improvement with the frequency of the gluten-specific T cell, and probably also the functional phenotype. But we're not quite there yet to use this measure to understand and monitor disease, but perhaps in the future we will be. So I'm going to finish there. Thank you all for your attention. These are a quick thanks to my team and our funders. And next time I hope I can chat to you in person. Thanks very much for your attention.
Fantastic. Yes, Dr. Abadi, I'd love to invite you on before we
Sure.
close out.
I mean, I'd like to, even if he's not with us, but I'd like to thank Dr. Tidin for giving this beautiful overview of his work and the implementation of this IL-2 whole blood assays, as underlined by Dr. Sylvester earlier, is a perfect example as one can learn from clinical trial and use this knowledge, because at the time they discovered IL-2 release, and use this knowledge to develop tools that lead to improving diagnosis, monitoring gluten exposure, and hopefully they're going to help also the development of new medication. And I really liked, I think, his last slides that really underline also where we stand and what we need with the development of several tools. He talked about IL-2, he talked about cytokines, he talked about gluten-specific T cells, and how we could combine different tools that we have identified over time to really develop new diagnostic markers for gluten exposure. So I hope that research can, in the future, be very useful to inform this new platform. Dr. Verma, do you want to wrap up this matinee?
I think that everyone's done an excellent job. There's so much we know, and there's so little we know, and there's so much more to go to. The stage was set earlier in the day when Anne was talking about, from a gluten-free standpoint, the diet itself, but really working at what she's doing currently with a whole group of people is setting up a nutritional assessment project. And that's really to standardize and establish uniform guidelines. I think it sets the stage from there, where we have gluten-free diet as a therapy. We're trying to learn more and set the stage for standardization. And we end today with really talking about how do we use other modalities like the cytokines for diagnosis and more so management, and how can we really utilize these tools for clinical trials or for medications in the future. I think Dr. Sylvester did an excellent job in terms of outlining why perhaps we don't have any drugs as yet, but we have hope that there will be drugs, and it just takes time and patience. And I also thank everyone for your patience as we've gone through some of our technical difficulties, so appreciate that. And thank Rachel and the team here at the University of Chicago for helping us put this together. The speakers have been phenomenal starting from this morning, and thank you so much for giving us your Saturday. And everyone else who's tuned in, and everyone else who will be tuning, hopefully listening to this on our YouTube channel. But Rachel will give you the finals in terms of how to get your CMEs as well. Rachel.
Yes, thank you, Dr. Verma, and thank you to you and Dr. Avadi and Dr. Semrad for helping us flow through this day. I really appreciate it. To our participants, please, we will send once again CME collection instructions. They are on the right below the schedule at the bottom of the page. Your CME instructions of how to claim your credit. They were again in the instructions from this morning, but I will send one more time to everyone after this program. But I just want to thank everyone for your participation and our speakers for giving your time and expertise. It is a truly phenomenal celiac community. And we are lucky to have one another and share knowledge and ideas. And we look forward to our next discussion. So thank you for joining us today. We hope you have a wonderful day. Thank you to the Celiac Disease Foundation again for your support, as well as Karen and Eric Simon for making this program possible. Thank you all so much. Have a wonderful day. Thank you.